thoracotomy. Several different reasons why you might need this. Usually cancer is going to be kind of your big one, or some type of diagnostic procedure for cancer related. They also can have trauma as well. Maybe they have cystic fibrosis and we need to take part of it as well. We're doing full transplants, that kind of stuff. And then cabbages as well. Usually we're going to go through number 3 there, the posterior lateral thoracotomy approach. That's going to give us the best visualization of that area. Again, post-operative wise, chest tube management is going to be crucial. It's going to allow for that full lung expansion to occur, and then also any excess drainage, any excess blood that may have occurred due to us cutting away a section of the lung. Okay. So usually it's going to be some type of video assisted type of procedure. And so we'll have some type of ultrasound, some type of camera that is going into that intrathoracic cavity. So we can get a good, nice visual of that space. This is a good picture, maybe a little extreme of a picture, but roughly the good position that your patient needs to be in for chest tube insertion as well. So remember that hands have to be up above the head so you can get a good visual of that thorax, those intercostal spaces, and that axillary space all right through there. So this is a really good representation of a chest tube placement position as well. Now, we can have some other things if we have consistent pneumos that have developed, or consistent hemothoraxes, or consistent fluid building up within our intrathoracic cavity. Besides a chest tube, I can also do a talc procedure as well. So it's kind of this slurry paste almost of talc that you're going to put within the intrathoracic cavity. It's going to cause significant amount of inflammation and scarring. It's going to kind of damage that space. And as that inflammation and scarring occurs, it's going to create kind of like a seal right there. And that scarring and fibrous tissue that has developed is going to allow for kind of that reattachment of that pleural space to that cavity wall. It sounds really painful to me because you're introducing a harmful agent almost to that intrathoracic cavity, and that's what's causing this kind of allergic reaction, this inflammation type of reaction for this. So remember, this is usually for something like a persistent pleural effusion, persistent pneumothoraxes that occur. I can do that type of procedure to do it. Very similar to, well, I don't know if any of y'all, they use it at the beauty shop, but at the barber shop, you know, if they cut the back of your neck or they cut you while you're shaving and they put that little powder on, everybody know, the men, you know what I'm talking about? And then they paint, that's very painful and hurts like crazy. Very similar, but we're putting it into the intrathoracic space. I don't know if they do that at a beauty shop. I don't think so. They put talc like powder?
Yeah, I did it to me before.
Okay. So maybe the same thing on there. I've never had a toe stuff done, but yeah, very similar. Okay. Here's the different kinds. I wouldn't get so focused on this, but you can have several different types of surgical procedures, thoracotomy procedures. So something like a pneumonectomy, I take the entire lung out. Lobectomy, I can take just a section of each lobe. So remember the different lobes between the left side versus the right side of the lung. Then I can take a section out itself, or just a wedge, just a little triangle, square shape. So usually for these wedges right here, maybe I had some type of cancerous or tumor, maybe some type of bleb, so it's just some kind of tissue that's been damaged within the pulmonary space, and I'm taking just that section out. Usually your pneumonectomies, it's going to be extensive cancer, extensive tumors, Sometimes like your cystic fibrosis patients, when they're doing a lung transplant, we'll take some out as well. Some different options out there. Generalized overview, what is my role as a nurse versus pre-op versus post-op? Now, it's not our ultimate duty to get a consent form signed, but more than likely we are going to get a consent signed. The physician has to educate the patient about the benefits and the risks of this procedure. However, once they educate them, more than likely we're going to have to re-educate and eventually get that consent signed as well. We're going to get a chest x-ray, probably a CT scan as well. If I'm going in, I've got to see the full extent of what's happening, the full extent of damage, where I need to cut each section out. So I want to get a good visualization of what's happening so that physician can go in there and know exactly where he needs to be at. Your PFTs or your pulmonary function tests, I kind of want to get a before and after of this. Make sure my patient is able to go through this procedure. His lungs are strong enough and he's able to protect his airway. So something with those pulmonary function tests can determine that. Want to get a bunch of labs, so I'm going to get my electrolyte panels, going to get my ABG to make sure I'm not in any kind of respiratory distress already that could cause more issues when I go through this procedure. And then I'm also going to get all my clotting factors and my blood levels as well to make sure. Big thing is going to be educating your patient. So the use of an incentive spirometer. Are we sucking or blowing on the incentive spirometer? Sucking in, right? Okay. Nice, deep, slow, deep breaths, trying to fully expand those lungs out. Most patients don't know how to use incentive spirometers, so we need to educate them on that kind of stuff. Splinting with that pillow, that's going to reduce the amount of pain. Make sure they're getting up and mobile. The less mobile they are, the more they lay in bed, that's going to encourage that atelectasis to group up. So getting those kind of stiff, non-compliant lungs, those alveoli are going to get sticky, non-compliant, not wanting to open up, fully expand for that oxidation gas exchange to occur. Post-op wise, I need to monitor my chest tube output. That's going to be kind of my big priority there. Going to monitor my vital signs as a nurse. Again, encourage that mobility, go on frequent walks. Some people have been to have been to CVICU. They get their patients up and moving, walking around a lot, right? Sam, you've walked your patients several times, I'm sure. So they're encouraging that mobility, getting that nice full lung expansion. If I have that atelectasis to occur, maybe I can even develop pneumonia at some point. So that's going to set me back even further than I already was. And so overall, we're just going to really monitor for those complications, whether that be the vital signs or pain management, notional support. That's really what we're going to be as a nurse. Okay? So that's what all this real section is going to talk about right here on this post-op side. So for your lobectomy, this is where we are taking out just a section of that lung right there. As far as fluids go, just a nice, slow, steady rate, nothing too serious. Don't want to fluid overload them. They're already at a high risk for increased respiratory distress. So if I'm giving too much fluid, raising my risk for fluid overload, cause them to be in more respiratory distress as well. This bullet point, this third one right here, is going to be kind of your big thing for your lobectomies. Lay on your back or non-operative side. And that's going to promote better ventilation and perfusion. So let's think about it. I'm laying on my non-operative side. That means, let's say if I had a right lobectomy, I'm going to be laying down on my left side. That's going to encourage all that blood flow to occur on that left side for it to pull up in there. because I want better perfusion to the good, healthy lung right there, right? That's gonna encourage increased oxygenation exchange because I'm having increased perfusion with that. I don't want all the blood flow or pool to pull up on that bad side where I've had that lobectomy to occur because I only have a section left of my lung. And then for pneumoectomy, now your big thing is going to be lay on the operative side or your back. So that's what's going to be different from your lobectomy. So I don't want all that blood flow to occur on that bad side, and so that's why I'm increasing it and putting it on that effective side. Okay? All about the VQ mismatch. So my perfusion versus my ventilation of my patient. Your physician's really going to tell you how often we need to turn these patients, when they're okay with moving them to the opposite side. We do want to move them pretty frequently to encourage any fluid buildup, break loose any of that mucus production, to hopefully get that up and out. So we do want to turn them, but it's going to be a physician call. Last thing, acute respiratory distress syndrome. With acute respiratory distress syndrome, some reason or another, I have some type of alveolar injury. I have some type of prolonged inflammatory response. So I'm having these stiff, non-compliant lungs that's causing an injury to those alveoli. So box 26.7, page 605 of your med-surg book is going to be those common causes of this type of injury. Yeah, box 26.7, page 605. So this can be anything like aspiration pneumonia. COVID-19 was a big one here recently. Pretty much everybody went into ARDS. Some type of severe trauma, shock, maybe an air emboli. So there's a lot of different things that can cause acute respiratory distress syndrome. With this increased inflammation, I'm also going to have an increased amount of fluid within my lung space as well. And that's going to be kind of one of those later symptoms. Your key feature with ARDS, so hypoxemia, even though I'm giving 100% pure oxygen. So even if they're on the ventilator and my FiO2 is at 100%, I'm still going to have hypoxemia. And that's going to be based off of my PO2. So my PO2, remember that normal was going to be at 80 to 100, so less than 80. Even though I'm giving them 100% pure oxygen, I'm still going to have that hypoxemia occur. So that's going to be really one of those big ones right there. It's going to be really hard to ventilate my patient. Remember, these are stiff, non-compliant lungs. So those COVID-19 lungs, those aspiration pneumonia type lungs, COPD lungs. So what am I trying to increase to hopefully ventilate my patient? To open up those lungs, create that better compliance.
The PEEP?
The PEEP, right? The PEEP, peak in expiratory pressure. The more I crank that up, the harder I'm trying to ventilate those lungs, to keep those lung fields open. Remember, that's going to be a big factor with that lung compliance. Dyspnea, and then pulmonary edema, not resulting from any kind of cardiac or heart failure, resulting from other issues. That inflammation is bringing in that excess fluid, which is going to cause that pulmonary edema. But it's not because of the backflow of that fluid from a cardiogenic standpoint. And then you're going to see this big time on a chest x-ray as well. A lot of times it's gonna say something like ground glass opacities. And that's basically what all your chest x-rays said during COVID. That was kind of our diagnostic tools for COVID-19 as well. Physical side, it's really just gonna be big on your respiratory distress type symptoms. So remember your respiratory distress type symptoms. So anything like cyanosis, dyspnea, tachypnea, your patient starts to breathe a little bit fast. Maybe they're in that tripod position. They're using those intercostal muscles. Our vital signs, what are our vital signs gonna look like?
Low O2 sat. High
Okay.
respiratory rate.
Good, what else? Tachycardia, good. Might have some hypotension too in our late signs, good. With that, we can also have cyanosis. We can start to have that pallor, ashen skin as well. So any of those signs and symptoms, I'm kind of thinking in the back of my mind, why am I having that? It could be a lot of different things. A lot of those signs and symptoms are very close to a pneumothorax or a hemothorax. Diagnostic wise, overall, what is my patient's major malfunction? Did they come in with flu? Or did they come in with COVID-19 or COPD? Did they aspirate on the floor and now they're on the unit and that's why they're having respiratory distress? Remember, like I said, we're having that high FiO2, so something like even 100% FiO2, but we still have that low PaO2. And we're gonna see that reflected on our arterial blood gas. So that's gonna indicate that hypoxemia on this other side. Our normal is at 80 to 100 on your PaO2, so you're gonna have that even further down. That decreased gas exchange, so we're definitely gonna be in some type of respiratory acidosis more than likely. We're gonna get lab values as well. We're gonna get a chest x-ray. That's where it's gonna show those glass opacities on our chest x-ray. And then we have something called a PF ratio. Has anybody heard that before? PF ratio. Any thoughts on the PF ratio? What it can mean? No. All right. What? No, no, not quite. So P, that's your PaO2. How much circulating oxygen was in our blood? That PO2 over our FiO2, our PF ratio. So it's kind of a good representation of how well I'm oxygenating my patient. With that, if I have a PF ratio between 200 millimeters of mercury to 300, that's going to be what's considered mild ARDS, mild acute respiratory distress syndrome. Anywhere from about 100 to 200, 100 to 200 is going to be your moderate. And then anything less than 100 is going to be severe ARDS. So your PF ratio is your PO2 divided by your FiO2. So 200 to 300, mild ARDS, 100 to 200, moderate ARDS, less than 100, severe ARDS. If you get into that less than 100 range, your mortality risk is pretty high. Okay. Now, how am I going to treat this? How am I going to manage this? More than likely, I'm going to intubate my patient. I'm going to place them on the ventilator. And remember, trying to ventilate my patient, I've got to increase that PEEP. I've got to increase that pressure to hopefully help with my lung compliance, open up those alveoli, recruit those alveoli, to hopefully create that oxygenation and CO2 gas exchange. Remember, my PaO2 level, how much oxygen was circulating in my blood, is low. I want to try to increase that. So I gotta create that gas exchange. So you more than likely, you're going to be on assist control. You're gonna be on that highest setting, that highest ventilator mode setting, and then usually we're gonna put you in pressure control as well. I'm trying to promote that alveoli recruitment. I gotta have enough alveoli to create that gas exchange. I'm asked also another option. This is not anything we do at East Alabama, but you'll see it at different facilities. Extracorporeal membrane oxygenation. That's a really fancy term for ECMO. I'm sure you've heard ECMO before, right? So I'm gonna put these large board catheters within my patient, and I'm completely bypassing everything. I'm bypassing pretty much the heart, bypassing the lungs as well. As I'm pulling this blood out, I'm hyperoxygenating it, and then I'm reintroducing it back into the body to perfuse how I need to. So that's going to help with my PO2. Because remember, my lungs are what's damaged, what is not acting appropriately, not oxygenating my blood appropriately. So if I bypass that altogether with the ECMO machine, and then I can potentially raise my PO2 levels with that. And it's a process when you're doing ECMO. Usually this is a one-on-one patient, sometimes a 2-to-1 patient. This is pretty serious, real deal stuff right here. Okay. Otherwise, to help promote gas exchange, positioning is going to be big. It's going to be key. Prone positioning. This is what's going to be big for your ARDS type patients. So during COVID-19, all our patients were in that prone position. With that prone positioning is giving a better chance for my lungs to expand fully out. That increased pressure because of gravity is not pressing down on those lung fields, and it's creating that better perfusion as well. So it's allowing for it to fully expand, creating that O2, CO2 gas exchange to occur. With your prone positioning, every facility is going to be a little bit different. Normally they like to recommend 12 plus hours a day. Usually they'll go up to 16 hours a day of prone positioning, and then they'll flip them back over onto their back, onto supine positioning. And then they'll be in there from anywhere 6 to 8 hours, and then they'll flip it back. And they'll keep repeating this process. Our main thing that we're looking at is a improvement of that PF ratio. Because that PF ratio is truly showing how well that I'm ventilating, how well that I'm oxygenating. So as that PF ratio improves, then my physician can consider maybe we don't need to be in that prone positioning anymore. With your prone positioning, your patient's got to be fully sedated. So remember, we got to have full sedation on board, but we also got to have full pain medicine on board as well. Because we're not just sedating, we're also helping with pain. And then their patient has to be fully out of it, and then we're going to paralyze our patient on top of that as well. Because I don't want them to move, I don't want them to cough, I don't want them to do anything. All I want to do is allow that ventilator to have a chance to help me oxygenate better. That's my goal. So fully sedated, fully paralyzed before I do anything. And then I can put them back and put them in that prone positioning. In this prone positioning, pressure management is going to be key. Skin condition, skin management is going to be big for these patients. A lot of facial edema is going to occur just because of the way we are positioning these patients. All that fluid and excess is going to accumulate in that area. So you're going to have a lot of lip swelling, just facial edema. You're going to have some of that periorbital, around the eyes type swelling as well. So sometimes we'll get ice packs put around their eyes. So that's why positioning is very important. We're going to move these patients every 2 hours, what we call swimming. And so we're going to put kind of one arm up one arm down, and that's how we swim them. And it's gonna rotate their hips, and it's gonna move their head. And then in 2 hours, and sometimes it's up to 4 hours, depending on your hospital policy, we're gonna move them the other way. And so we'll have them swim this way. So kind of how you think about when you're sleeping on your stomach, that's how we're positioning these patients. And we're moving them back and forth, kind of rotate them. As they're rotating, that's creating that pressure management, all right? So, because remember, you gotta turn your patients every 2 hours, right? Even if they're on their back and you're putting a pillow on one side and the other, same thing. We gotta care for their skin the same way. Now, there was a group of students that prone a patient, which was pretty cool, in the ICU.
It's
What-
amazing.
What did you think?
It worked. I mean.
It's really cool, right?
She's D-side every time we touched her, but we flipped her and all the numbers got back.
Okay. Was it a pretty scary procedure
Yeah,
process?
because that's usually when they code, right?
It could potentially while they're coding, yeah. What do these patients have? They have a ventilator, right?
Mm-hmm.
If they're getting all these paralytic sedation, maybe they're on some type of pressors. They're gonna have a central line as well, right? Okay? They're gonna have an arterial line as well because they're on pressures and all the sedation and stuff, because they gotta constantly monitor their blood pressure. Maybe they got a chest tube as well. Maybe they're on ECMO. You know how many lines that is? That's a lot of stuff that's starting to accumulate around my patient, right? And now I wanna flip my patient like a hamburger all the way over. That's a lot of chances for something to get dislodged, right? So that's one of the big complications as far as proning your patient. It's the dislodgement of the tubes, the drains, your endotracheal tube. There's a lot of factors that play into it. So there's a lot of resources that are involved in flipping that patient. So how many of us were in there?
There was like 12 of us.
Yeah.
There's like 12 of us in there, yeah. So there's like 4 on one side of the bed, there was 4 on the other. We also had 2 respiratory therapists in there as well. Early days when we were proning, kind of in the beginning stages and getting used to it, we also had a physician in there as well, sometimes 2 physicians, to really break it down. And if anything dislodged, they were able to put it back in quickly.
She was 350, she was.
Mm-hmm.
Yeah, she was on the unhealthy side, and that's kind of one of the contraindications for it. I kind of disagreed with
Just had chest.
the prone procedure, yeah. I'll talk about it in just a second. So, airway obstruction. So I can move this tube, maybe it doesn't fully come out, but maybe it moves up 2 or 3 centimeters. So that's why it's important to assess the measurement on that tubing. Or maybe it's kinked off for a significant period of time because of that positioning, because of my patient's airway positioning. It's not creating just an easy, nice pathway for that ventilator to work appropriately. And you also have something called brachial plexus injury, so an arm injury, because of the way we're positioning these patients. It's causing that nerve damage to occur within those as well. Now, contraindications in this. Severe bleeding. If they have real acute severe bleeding, I probably don't want to flip them to prone positioning. Increased intracranial pressure. When I'm doing this, I'm creating a significant amount or increased intracranial pressure because of the way I'm positioning my patient. Some type of unstable fracture. It's really hard to move, position, maneuver these patients, position them again, these patients, to keep that fracture stable. And another big one is abdominal type of surgeries. Don't really want to do that with that. And obesity can be a big factor into it as well. Now, the other week when we proned our patient, she had a big open abdominal incision, so that's usually a no-go. And then she was also on the obese side, which is also a no-go as well. But this was a last-ditch effort, last-ditch attempt to hopefully oxygenate this patient. So sometimes those contraindications can kind of be put by the wayside because we're just trying everything we can. It's kind of a desperate last attempt to help these out.
Situation like that, just in general, do you need a doctor's order for prone?
Yes.
Yeah, the charge nurse got upset that we did it.
Yeah.
That the doctor was like, I gotta do it.
we kind of butt heads with a night shift hospitalist sometimes. He's a really nice guy, he's very smart at what he does, but, sometimes you just really disagree with the physician. It just happens that way, but yeah, it is gonna be a physician type of order. And it's really, again, based off that PF ratio that we get. So when we get that arterial blood gas, I see my PaO2, they can calculate the PaO2 based off what the FiO2 is. And sometimes the computer will do it for you if the respiratory therapist plugs in all the numbers and stuff while she's running that blood gas, and it'll give you a PF ratio. And there's certain parameters that we follow to do that prone positioning in there. So it's gonna be that physician protocol. So with that prone positioning, remember I gotta have my sedation, I gotta have pain management. I'm not titrating these up and down. My patient's gotta be that RAS of -5 fully out of it, because then once I paralyze them, I really don't wanna mess with any of my sedation. I don't need my patient awake, paralyzed, because that's torture, and we don't wanna do that. So remember your train of 4 as well, to account for how paralyzed my patient is. So remember that 4 twitches. I'm doing a little bit of nerve stimulation, kind of like the TENS units. I'm doing a little bit of nerve stimulation. If I get 2 out of 4 twitches on that train of 4, that's optimal, that's what I want. And then if I get 1 out of 4 twitches, my patient's too paralyzed. 3 out of 4 or 4 out of 4, my patient's not paralyzed enough. So I'll titrate my paralytics based off of those twitches, okay? Usually when they are prone position, we're gonna use this temple nerve right here because it's just easy access. It's gonna be what it is. What if my patient codes? What happens then?
Do it just like that.
Do CPR.
Do CPR on the back, yeah. Scary thing, but it happens. And so usually originally, when we were first doing this, we would flip them over, then code them. But now, new research says code them on their back. So that's what we'll do.
Put the pads on.
Put the pads on them, but remember, everything's in reverse because they're prone, right? So your heart's gonna be on the other side.
We put our pads on before we flip.
Yeah. Because we thought she was gonna code during
Right.
prone. But if you don't put them on, usually we try not to keep them on because they're gonna be laying on that one side, and that can create a pressure injury. And then all your leads are gonna be different too. So remember your left and your right, they're gonna be opposite. All right, but really the only one that's gonna be the same is the brown lead, the V lead there, because it just goes in the middle. But everything else is gonna be opposite because they're laying on their belly instead.
It will read the same.
It will read the same. There's like a slight difference. And then if you do the 12 lead AKG, remember we're outlining the heart. So if they're in the supine position, we do it this way, but the other way we're gonna go the other way. So remember, we're trying to outline the heart for that 12 lead AKG. So everything is in reverse. Okay?
Yeah.
Now, there's really no specifics for treating ARDS, to treat it specifically. It's all about symptomatic management at this point. Once they develop ARDS, I've got to fix all their symptoms. So the big things, their oxygenation consumption. Remember that PF ratio is going to be severely decreased. How do I fix that? Prone positioning, mechanical ventilation, increasing that FiO2 if I can, increasing that PEEP if I can. Fever control, so something like Tylenol. If it's infection based and that's the reason that they went into ARDS, then I need to fix that. Control their temperature. When I'm controlling that temperature, I'm also creating less demand on my cells because this increases that cellular respiration and it's causing more demand to my tissue. And I don't want that to occur because I'm already having a decreased oxygenation as well. Same thing with glucose management. So they might even be on an insulin drip at this point as well, plus all the sedation, plus the vasopressor. So we're starting to add a lot of IV pumps here as well. What if they're on ECMO? Sometimes I'll put them on heparin as well. And then maybe if it's a pulmonary embolism, I can have heparin as well, so I'm adding a lot of different things here to it. Nutrition wise, that's something I forgot to mention when we're flipping as well. They're gonna have some type of NG tube in as well, cause I have to worry about their nutrition. I gotta get that protein in to encourage healing to occur. Maybe they'll have, a lot of times we're starting to introduce what's called a DOPHOV now, which is kind of a fancier NG tube. With it, it's a very thinner, smaller, pliable tubing than the traditional NG tube. The NG tubes are technically not designed for feeding, but we use them often for it. NG tubes are usually used for abdominal decompression. That's the original intended purpose for it, but we do use it for feedings. With the DOPHOVs, these are ultrasound guided, and you have to be specially trained to put these in. They have a little magnet on the end of it, and it guides it through, little magneted, weighted, guided in, and you can see that on the ultrasound. And as you're placing it in, you'll see it actually circle through, down into the esophagus, it goes down into the stomach, and then our goal is to actually get it past that pyloric sphincter. So it goes right past the pyloric sphincter, down into that small intestine, and that's where it terminates, that's where it hangs out. Yes?
What is it called, DOPHOV?
DOPHOV.
What are you saying?
I think it's DOBHOFF. That doesn't sound right though, look it up.
Okay.
Yeah. I'll look it up in just a second, but DOPHOV tubing. And I think that's the brand name too, so it's just a specially guided feeding tube, small bore feeding tube. Is what the, just generalized term is, small bore feeding tube. Why do I care that it goes past that pyloric sphincter?
Absorption.
Absorption? Yeah, maybe.
Inspiration.
You're right. It's DOBHOFF.
Hey, I can spell. What'd you say? Somebody else said something. I heard absorption. What else?
It's aspiration.
Aspiration. I like aspiration. Good. It's not allowing for all that nutritional feed to accumulate in my stomach, right? The more pressure that I create on my stomach, because remember, I'm in that prone positioning, so that's gonna increase my intra-abdominal pressure, right? So I'm gonna have a very high chance, high risk of aspiration because of all that added pressure. So if I'm infusing a bunch of tube feeds into that stomach, that's even more risk. If I go a little bit past that pyloric sphincter, now I'm shooting it a little bit further downstream into that small intestine, that large intestine. It's not creating so much intra-abdominal pressure. And more than likely, it's not gonna come back up through the pyloric sphincter. Because remember that pyloric sphincter closes, allowing for food to sit within your stomach, and then it opens up to allow food to pass through into that small intestine. Nothing ever should backflow. And then VTE prophylaxis, that's pretty much everybody in the hospital. Everybody that comes to me doing the Pyxius is basically gonna give Lovenox. That's what's gonna happen here. Fluid electrolyte replacement. So if any kind of mag is off, potassium is off, I'm trying to get these patients as stable as possible. These patients can go downhill in a hurry. They are very sick patients. These are really good patients to have though. I love these type of patients. These are good ones. Hemodynamic monitoring. Remember, we're gonna have that arterial line in, we're gonna have that central line in, so I'm constantly monitoring that blood pressure. I can even connect the CVP to it as well because I have that central line in as well. And then usually we're gonna do some type of antibiotic therapy as well. Sometimes even prophylactic just to cover our bases for that. Okay, questions about ARDS? So what did I keep talking about?
Chest tube management.
Chest tube management, right? So is chest tube management gonna be important?
Yeah.
The two
Wow,
different
this is-
positions for the lobectomies.
Okay. And positioning.